Hello everyone. Thank you for taking time out being here for today's webinar, which is the second one of the Maternal Nutrition Technical e-dialogue series hosted by ICMR National Institute of Nutrition and Federation of Obstetrics and Gynecological Societies of India in association with UNICEF. Other partnering agencies for the series are Alive and Thrive, Nutrition International, Society of Applied Studies, Institute of Economic Growth, Sight and Life. I am Dr. Rajni Peter, Program Coordinator at NIN. Many of you must have joined us in the last month's webinar. Hope you found it informative. Through this series, we aim to explore the ways by which maternal nutrition assessment and services in antenatal care can be strengthened in India. In today's webinar, we are discussing the rising burden of maternal obesity in India and the ways to tackle it. We have many eminent speakers and experts in our panel. If you have any questions, please put them in the Q&A box. Our experts will try to answer them. If time permits, we will have a short Q&A session in the end. Let me now introduce Dr. Bharti Kulkarni, who is the convener of today's program. She is the Senior Grade Scientist F and Head of the Department of Clinical Division at ICMR-NIN, who is the convener of today's program. Dr. Bharti is a Senior Scientist and Deputy Director here at NIN. Her major research interests are in the areas of maternal and child nutrition, anemia, developmental origins of health and disease. Dr. Bharti, over to you, ma'am.
Thank you, Rajini. I'm very happy to welcome you all, panelists as well as participants, to the second webinar of the monthly maternal technical e-dialogues initiated by ICMR-NIN along with FOGSI and other partner institutions, including UNICEF, Sight and Life, and other organizations. We had a very fruitful discussion last time on maternal thinness. Today we are going to discuss in depth about the rising problem of maternal obesity in India. Recent fact sheet data by the fifth round of the National Family Health Survey really shows alarming trend of increasing obesity in men as well as women of reproductive age. And this is the other end of the spectrum, and our healthcare systems and government programs are geared towards undernutrition. And this situation of double burden, we need more nuanced strategies to screen and also manage the adverse impacts related to maternal obesity. Practicing clinicians also need these guidelines urgently. So we are very fortunate that we have very eminent speakers and panelists who are willing to share their knowledge and discuss about the strategies to go forward on this. So without wasting much time, I would like to I'm very thankful to our chair, Dr. Prema Ramchandran, and Dr. Alpesh Gandhi, who have consented to be chair and co-chair for this important webinar. Without wasting further time, I would like to introduce our chair, Dr. Prema Ramchandran, who has always been a pillar of support for everyone working on the issues of maternal nutrition in India. She's former advisor, Health, Nutrition and Family Welfare to the Planning Commission. Currently, she's the director of Nutrition Foundation of India, and she has done seminal work on maternal nutrition and is a very well-known name in this area. She has had an illustrious career and has received a number of awards. I would like, ma'am, to request you to give your opening remarks. Thank you.
Thank you, Bharati. As you had started the session with the statement that we, at the moment, are still grappling with the problem of maternal undernutrition, anemia, and its adverse consequences on mother-child diet, we also have to learn how to cope with what, to my mind, is a far more daunting job. trying to detect, manage the overnutrition problem, which has three major components. One is the women in reproductive age group who are, even to begin with, before in the pre-pregnancy period itself, are overnourished. The second is the creeping overnutrition, excessive weight gain to their height and weight, which is happening during pregnancy, which is leading to a post-pregnancy weight reduction, weight retention. And a third, starting with pregnancy and lactation as the first period of weight gain, it sort of enables them to reach the higher age group with a greater and greater proportion becoming overnourished. So actually the pregnancy is the first step in the path to overnutrition. We have to take into account the fact that our pregnant women are in their early 20s or perhaps mid 20s and still have another 25 years of reproductive age group. And if the current trend in terms of life expectancy, if we extrapolate for the next 50 years, after they cross 50, they have another 35, 40 years. So that is a very daunting thought. It begins in pregnancy, but it is going to influence their entire life. So it's extremely timely that we are taking it seriously. And very often, pregnancy gives an entry point to the physician and nutritionist. We should use this opportunity to ensure that women really do not incur greater and greater health and nutrition problems through overnutrition right through their life. Thank you, Bharati. I'm looking forward to listening to all the presentations now.
Thank you, ma'am, for your words of wisdom from your years of experience. I would like to invite our co-chair, Dr. Alpesh Gandhi, President of FOGSI, to give his remarks. Before that, I would like to quickly introduce him. Dr. Alpesh is the president, practicing as high-risk pregnancy expert at Ahmedabad since 29 years, and he has been a resource person for FOGSI's GCPR on pregnancy and COVID. He has had a very illustrious career, and he has been on many committees, and he has been awarded as honorary FRCOG. He has been awarded orations and keynote addresses by many gynec societies across India and internationally. And he has kindly agreed to give his time for this. Last time also he was there. We are very fortunate for support of Dr. Alpesh Gandhi along with FOGSI. May I now request Dr. Gandhi to give his remarks.
Namaskar. I think I can see Dr. Gandhi in some other meeting at some other inaugural function, so I don't think he's around here. So
sorry.
We might as well proceed, yeah?
Yeah, fine. Okay. I'll hand over to Rajni now.
Okay. So let's get started now. It's my pleasure to welcome two eminent speakers for the first presentation, Dr. Vani Sethi and Dr. William Joe. Dr. Vani Sethi has about 20 years of experience in nutrition services for vulnerable women. She is a consultant, adolescent and women's nutrition at UNICEF. A common thread in her work is partnering with women collectives as equal stakeholders in decision-making and implementing programs. Currently, she is leading Adolescents and Women's Nutrition Impact Evaluation Swabhiman. Dr. Vani has several publications, book chapters, and journal supplements to her credit. The second speaker for the first presentation is Dr. William Joe, who is a PhD in economics from JNU. He is an assistant professor at Population Research Center, Institute of Economic Growth, Delhi. His research interests are in the field of health economics, demography, development economics, and program evaluation. Currently, he is providing research and technical support on maternal and child health for Ministry of Health and Family Welfare, Niti Aayog, Tata Trust, and the UNICEF. Dr. Joe also has several publications. They will be presenting the population estimates, consequences, risk factors, and management of maternal obesity among pregnant women and mothers in postpartum in India. And they'll also suggest some policy recommendations. Over to you, Dr. Sethi and Dr. Joe.
My screen is visible?
Yes, it is visible.
All right. All right, friends, good evening to everyone, and thank you for this opportunity. What William and myself will be presenting is a background paper on obesity during pregnancy in India, which we've put together for this webinar. We'll be trying to cover the areas which have been mentioned on the screen. Now, what we all know, we would like to begin with that, is that maternal malnutrition, we know, is an important cause of preterm birth and fetal growth restriction. Not undermining that infections, demography, environmental factors play a role. Within maternal malnutrition, all forms of malnutrition are important, which relate to underweight, short stature, anemia, weight gain in pregnancy, overweight, as well as micronutrient deficiencies. Each of these are risk factors. Oftentimes, programs are done with propelling towards one risk factor, avoiding the other. But what we also know is that in today's time, Indian women are entering pregnancy with more than one malnutrition risk, whether it's thinness, obesity, anemia, being short, being young, or having one or the other risks together. For example, in today's webinar, given we're talking about obesity, while we have 21% of Indian women suffering from obesity, we also have 18% of them suffering from both anemia as well as obesity. We also know that the prevalence of obesity amongst Indian women, even before they enter pregnancy, has been increasing significantly. Obesity in pregnancy is not only causing various harms to the mother, but also the child, which we all are aware of, particularly macrosomia, preterm birth in the child. We also know that pre-pregnancy matters, and hence common guidelines on one message of each pregnant woman just gaining the same amount of weight may not matter. Pre-pregnancy BMI based weight gain in pregnancy matters, and we do not in India oftentimes, or most of the times actually, have a pre-pregnancy BMI monitoring charts or even guidance available. We also know, and this is the last part before I enter into the actual work, is diet or exercise or both. They play an important role in tackling excessive weight gain in pregnancy. And basis this, out of the recommendations for nutrition by WHO under the antenatal guidelines, which are 14 of them, one guideline is related to overweight obesity, which links to healthy eating and active lifestyle. And this has largely been based on the systematic review summary, which I have shared on top. So if that's all what we know, then what does this study add? This study, which we are presenting today, is an evidence synthesis. It's a synthesis on the national prevalence and risk factors. It tells you about how antenatal obesity has been managed through a single or a combination of interventions, how India and other countries, particularly in South Asia, are screening and managing maternal obesity. Then what are the factors that are shaping the obesogenic food environment? And finally, given that the NFHS 5 fact sheets have been out, what are its implications and some prelim results on tackling maternal obesity, which my co-speaker, Dr. Joe, will take us through. What methodology have we used for this systematic review, which we are trying to share, is the obesity cutoff that we are using is the Asian cutoff. We're providing you for prevalence, risk factors, trends, and projections. We've used the analysis of NFHS 4, where we filtered the sample of 16,000 odd pregnant women from the NFHS 4 sample that were in the pregnancy less than 20 weeks. We've done a desk review over the last 10 years, and we've also deep dived into the CNNS data where the data on physical activity or diets would not be available. Trends and projections we're giving you from NFHS5. For what has been done to manage obesity, we did a review. It was a modified PRISMA approach. We saw records, and finally, the 12 full text items that were available on outcomes as well as interventions. We are presenting you some information on that. We've looked at several government guidelines, stakeholder interviews. We have been carrying out on what could be the systems approach, challenges and opportunities to really tackle maternal obesity, both from a screening and management point of view. And finally, to also look into the nuances of the enabling environment, we looked at the sales data of some healthy food items from the Euromonitor and FAO Stat, and regulations, both in terms of marketing, labeling, and media. This is the evidence synthesis, friends. It was done as a huge collaboration with an academic institute, with several colleagues from FIGO, FOGSI, UNICEF, the government. 3 of us are here right now. Finonella, Dr. Girdhar, and Dr. Baswal, who must be the participant, and ourselves. And at the same time, where, as I had mentioned, this paper was not enough, we went into a deep dive on a landscape study on overweight obesity in children and adolescents, and we looked at maternal obesity as a risk factor and all the factors looking at it. What did we find? And I'll walk you through some of the important findings. That the first foremost, the prevalence. If we look at the prevalence, and this graph very, very simply tries to explain that on one hand, where you have mildly thin women, at the same time, you will see an equal proportion also moving into an overweight category, and around 5% being in the obese category. It tells you very creatively that while we are trying to address mild forms of thinness, at the same time, in the same proportion, overweight is also increasing, probably at a national average at the same percent. But India is large, so are its states, and with its diverse districts, which are 700 plus. If we look at the prevalence, where we say that in pregnancy, if 13% of the women are suffering from overweight obesity, we see 31 districts across India that have a 40% or more prevalence. Highest being in Jammu and Kashmir, trying to say that there is a variability. This variability is not that it is concentrated in one region. However, the central belt still remains a miss. And towards the corners, we can see that the prevalence of overweight obesity is increasing. What could be some of the risk factors? Based on the analysis of the NFHS4, what we find is older age, urban residents, secondary education, and in the highest wealth quintile, if you have a more likelihood of being in the obese category. And while diet plays a role, our analysis did not find it to be statistically significant for various reasons, which I will inform, because we didn't have data as captured in the NFHS4 on consumption of sugar-sweetened beverages, quantity of processed foods and carbohydrates, and at the same time, also data on physical activity is not available in NFHS. The point trying to make is, as you move on to higher levels of education, as you're moving on more and more urban residents, the likelihood of being overweight obese increases. Is the problem getting worse or is it improving? Well, it's worsening. The pace in rural is actually faster or for worsening, and not just the poorest quintiles. If you look at even the poor quintiles, as you can see here in the second part, it is increasing. Where the CAR, that is the compound annual growth rate, is about 14% in the urban areas, but 20% in the rural areas. So the poor in the rural areas are moving and are suffering more. If you look at studies that have been conducted, not just the studies for NFHS5, but also overweight obesity studies across in local studies, those studies are also showing some of a higher percentage and not just a percentage which is 13%. So it's moving even higher. And those are studies not only in Tamil Nadu, which is showing the prevalence of obesity in pregnant women being nearly 30%. But even in Chhattisgarh, the studies are showing that this is moving in a worsening direction. We know the causes and its risk factors of obesity to GDM, hyperglycemia, and this data not only from studies by Nielsen, local studies across rural settings around 7 odd states, all show that the GDM percentage of pregnant women suffering from hyperglycemia and also the hyperglycemia related live births are increasing. If that's what to do with the prevalence and the risk factors, the food environment then also plays a role, because it's not what you only consume in the homes or where you're living, but where you're living also is, and what you're eating is influenced by where you're living in the food environment. If you look at what the food environment data shows, it shows that the sales of confectioneries have actually increased almost 10 times to that what would have been the increase in pulses. Not only that, the sales of packaged and processed foods has actually doubled between 2012 as well as 2018. And the annual sales of the Pepsi and the colas, which are holding large proportion of the shares, is also doubling, specifically with the sugar and sweetened beverages sales. What's happening on the media front? If you look at the media and the type of advertisements, the type of emulative media marketing strategies that are happening, they're all enticing the women, the family members and the kids towards SSBs, that is sugar sweetened beverages, and the HFSS foods. And in terms of the amount of money that is spent on these foods and advertisements alone around specifically games and the events is large. Habits are friends formed very early in life, specifically at home. And what we wanted to bring is that we really wanted to see the data on diets, because what our data showed us was insignificant association. So we really wanted to go back and see that, what are the kids and the adolescents then eating? Because that's what they would be eating, would be the ones which other family members are also eating. And if you actually look, what's really missing from the plate is the fruits, greens, and eggs. Even once in a week, 3 out of 5 girls are not eating. And this is data from the CNNs that we are trying to show. And the consumption of unhealthy foods is increasing. But at the same time, the types of unhealthy foods that is consumed by both girls and boys is largely fried foods. Now, fried foods like pakoras, jalebis, samosas are not even considered as junk foods in India. And that's the type of food items which we feel could be causing more harm than good. What's happening now to the other aspects of the food environment, that is the lifestyle. And again, because NFHS does not provide you that data, we looked at CNNS. And if you really see that the screen time is increasing, outdoor physical activity is reducing, specifically as age increases, and at least 15 states don't even meet the basic requirements of physical activity of 60 minutes. And that's going to go all even in adulthood and pregnancy. If that's the story of prevalence and also the story of what's affecting it, then what are the management options specifically related to pregnancy? We're trying to show you 2 management options here. One, which has come out from research, and the second, what are programs and governments doing? If we look at research, we did not find any research related to management options in South Asia or India. What we have, whatever studies that we found, that is the 12 studies which we were able to shortlist from the PRISMA modified methodology, were all RCTs and in developed countries. And the types of interventions that have been used are either counseling, counseling plus diets, counseling plus weight gain monitoring, counseling plus weight gain monitoring plus physical activity. And so these are the types that have been done. either being provided weekly, bi-weekly, for a duration also varying. So it's really a mixed group. The types of, that's what the literature shows. The participants have largely been pregnant women, and in 12 studies, 8 of them have been obese. So what does this show? And I'm going to give you a snapshot of this with the details being available in our background paper, is that first, if you look at the first intervention, that is counseling on diet plus physical activity, the 3 RCTs, verbal counseling being provided every 4 to 6 weeks, and it showed that the results were more in the obese category women, Kelly methods, no results, and largely no significant results on gestational weight gain for normal women. The second intervention, what happens if you just do a supervised physical activity? 50-60 minutes of exercise was resulting in reduced cases of excessive weight gain only at the 9th month of gestation. What about the counseling? If you provide counseling and you also do self-monitoring of weight gain, there were mixed results across the 5 RCTs. And there was improvements in the gestational weight gain, but not statistically significant. What about counseling, self-monitoring of the weight, as well as supervised physical activity? And here it was the study in US by Fellan et al. Showed that there were improvements in gestational weight gain. It was good that there was an individualized and a structured meal plan. They provided a pedometer and 30 minutes of physical activity daily, and this showed to have show results. So when you really provide individualized counseling with a structured meal plan and 30 minutes of physical activity, they showed it worked. And the last was largely about counseling and just giving a diet supplement, and they showed that it did not work. Now, what about program response? And let's start with India. India has a bouquet of different nutrition interventions for pregnant women, varying from nutrition assessment to nutrition supplements, deworming, giving a balanced protein energy supplementation, gestational weight gain monitoring, counseling, complementary interventions like cash transfer, insecticide treated bed nets, and family planning support. There is also provisions for screening and management of nutritionally at-risk pregnant women. However, that's largely related only to anemia. Gestational weight gain monitoring provision is there. However, largely we see it's only related to HB monitoring, and gestational weight gain monitoring we don't see much. And counseling services, the challenge what we find is not gestational month-wise or risk-wise. Opportunities where overweight obesity has been attempted to be layered or addressed are the PMSMA, which is very recent, and a little in the gestational GDM guidelines. How they've been rolled out, what has their effect been on excessive weight gain is still to be known. Another program response is the take-home ration. Now, the take-home ration, different states provide it differently, and this chart tells you that how it has been customized for women with excessive weight gain, or or in geographies or hotspots that you saw with excessive weight gain, or with or without morbidities, is still to be known. Another new initiative which has been started just but late 2020, and it has not been rolled out, is for the first time having counseling cards based on pre-pregnancy BMI, and which using the Asian cutoffs where women are to be, where pre-pregnancy BMI is to be taken, and based on that you provide counseling. And NIN was instrumental in putting this together for the ministry. This has not been rolled out as yet. However, again, the counseling, the recipes that have been put together will need to be revised based on the EAR, because these were based on the RDAs. What about the regulatory response in India? India has a good regulatory system for overweight obesity, and and in recent years. However, while it has been reflected in national health policy, halting of obesity, both in women or in children, is not a part of the national nutrition mission. Although there are targets for zero trans fat consumption, which have been set, and FSSAI is working in those directions. If you look at guidelines, there are no specific guidelines on prevention and management of maternal obesity, which can be used across different comorbid conditions. It's been alluded in the NCD and GDM guidelines. If you look at taxation, which plays an important role in controlling the food environment, yes, there are laws of taxation of variated drinks, processed packaged foods, and some states started off with the fat tax also in restaurants. like Kerala. However, this has been discontinued. If you look at labeling, which plays an important role in supporting women make choices of what to eat or not, there is a regulations act and regulations, draft regulations were out by FSSAI. However, we are still to see some progress on rollout of these, as well as the front of package labeling. And we do not have nutrition information on food items in venues when women go out on so that they can actually have healthy choices. Looking at the regulatory responses from media, these are not either not amended, they're very old, or they're not affected. And this is a study that was done by WHO, and it was beautifully actually tries to map onto what information broadcasting ministry can do and what they can do more. And it's clearly that while there are provisions, the provisions for penalizing endorsers and advertisers for high fat, salt and sugar food and the sugar sweetened beverages is very, very poor. Another mass mobilization response, which we've seen in recent years, is both by the Ministry of Health and FSSAI, where on one hand, the types of yogas that can be done, the type of yoga that can be done in pregnancy is being trying to be promoted through Ayush. Several food items which can be eaten in pregnancy through recipe books has been done through academic partnerships with nutrition colleges, trying to reach out and mobilize dietitians to go on to PMSM day, because there's enough waiting time, but the health providers do not have time. At the same time, trying to have women for wellness camps for women at workplaces by the Ministry of Health, and Doordarshan coming to have monthly programs on maternal nutrition, which includes overweight obesity. So the momentum has started. How this momentum can be tapped and moved is now to be both evaluated and masked. An important contributor in this mass mobilization is the Eat Right India, and Inoshi ma'am is here, so she'll be talking about it. But starting from the Eat Right India, moving into Eat Right campus, and then bringing together a network of nutrition professionals which are largely faculty members and are trying to, in their regions and communities, spread awareness about the issues also started. So there's scattered initiatives, how they can be put into one framework for providing a mass mobilization response is something which needs to be considered. What are other South Asian countries done? And I think it's only Sri Lanka that has started working on the overweight obesity agenda. And why? Well, because now they're in a situation where 45% of women of reproductive age are in the obese category. What do? They start with the newlyweds, identify them in the eligible couple registers, sensitize them on a service package for preconception women, which is listed here. But importantly, what they do is that in addition to the vouchers that they're providing and the take-home ration, just like India, they're providing, those women that have the BMI greater than or equal to 25, they help them to lose weight before they become pregnant. They do not recommend dieting. They assess and modify the dietary habits in the first visit, while through the 24-hour dietary recall. They advise on specific messages of reducing starch, fat, and sugars, various myths and misconceptions, educate them on an expected weight, regular exercise, and screening for other complications like hypertension and diabetes. What about India? India, under the leadership of Dr. Himanshu Bhushan and Dr. Dinesh Baswal, an attempt was made to initiate the process of starting and development of a toolkit and institutional support for antenatal nutrition services in India. At that time, with Dr. Baswal's leadership, a lot of effort was made to understand the issue. And while IFA guidelines were there at that time, 2014, deworming and calcium guidelines were just initiated. And Prema ma'am is here, and so is Somesh, who would know where the momentum started, that we need to do more on maternal nutrition and not just have them as individual guidelines. A review of literature, identifying nutrition colleges, motivating them to start anchor this work, bringing the medical colleges and nutrition colleges together so that a protocol could be developed. It could be tested across various tiers like Kalavati Saran, Lady Harding, Lal Bahadur Shastri Hospital, and Lady Urban College, and various other nutrition colleges, first in-house and then moving out to the field to test and improve and simplify this in a program effectiveness mode through 8 states, and trying to test this out across all tiers, PHC, CSC, OPT, what could happen in a PMSA, in an NRCs and visiting dietitian model, and then continuing to simplify this and trying to do this not through only research, but through government PIP, and continuing to do consultations and continued consultations for revisions and revisions, with harmonized partner support, so that there were 17 partners across 8 states, led by the Maternal Health Division under the leadership of Dr. Baswal at that point in time, and with an academic anchor, how to really simplify, algorithmize nutrition counseling in a systematic way. All these materials are available. As you can see here, a toolkit was developed. Lady Urban College has a national center on diets, and they were requested to come forward to anchor all this work and put it as a repository. Any of you all are interested, you all can have a look at in those. All the materials are available here. What finally, after all the efforts of so many years, testing it first in academic centers, testing it then in the field, what was arrived at was 5 actions. Simplify it on, do the nutrition assessment, ask certain things, and specifically for nutrition was eating habits and physical activity, basic measurements of height and weight to ensure, look for certain signs, test your hemoglobin, give the micronutrient supplements and deworming, counsel specific only to the gestational month. It takes 10 minutes, friends. We did several studies on waiting time, but it was before the gestational month. In India, you know, every time we just give messages, there are 5 messages on what to eat. Well, if a mother is on a 2nd month of a pregnancy, she'll want a message for that. She wouldn't want a message, generalized message. So simple cards, 9 cards, 9 months of pregnancy, and only if on the 2nd month, if a woman comes and you give her that message. Then you classify the risk. Is she short? Is she thin? Is she young? Is she overweight? Is she obese? Or is she anemic? She may be 2 or she may be 1. And then you pick up the card for another 15 minutes. You give her the counseling based on that risk. If she has comorbidities, which are anyway assessed during the ANC, you test, treat, and refer. So algorithmize it, and then to say that, well, you need 25 minutes for counseling, individual level, and this is based on the systematic review that we just showed you previously, that individualized counseling rather than tele-counseling for this much time at least makes a difference. What is the cards materials that are they have been developed now for do's and don'ts for obese women? So I mean, what are the specific messages for obese women? I hear what to eat, what not to eat, the physical activity, and providing some replacement meal options, and no weight loss advice. But the point we are saying is that all the materials were developed. So over a period of 3 years, it took to develop all these materials with anchorage from the National Center of Diets at Lady Urban College. Now, as a programmer, you know, getting academics to do something, doing RCTs is one thing. Scaling it up in the field is a separate issue. And I think all this exercise, it helped us bridging the gap between academics and programs, because everyone was working together on one level. It actually threw light on various systems level challenges, and this is something which I'd like to share with you. The first and foremost is implementation, guidelines, and accountability. Now, the first thing which we saw is nutrition assessments and actions are not really taken consistently and comprehensively. A nutrition assessment of even a height and weight is not prioritized. It is not prioritized because it's not asked. Several guidelines don't have measurement of nutrition assessment as part of it, or even validation of those equipments. Accountability, most of the guidelines that are there, they give you simple messages, but they don't have a nutrition management section. What do you do for management? For example, if a high-risk pregnancy guideline is developed, does it have a separate algorithm for maternal thinness or for obesity? Well, not, then it should. Plans, heads are available in terms of PIP, but are the heads available in budgets for training, outreach, equipment, and supplies for nutrition? We've seen that, and there are gaps. Specifically, maternal nutrition requires either counseling cards or digital methods, or even a worker, to do it, some printing activities, but oftentimes not listed. If you look at demand creation, a most important one, which needs gestational month-wise cards, it would need engagement of dietitians, it would need a private sector provider, which we see are missing. Friends, is a huge vacancy load anyway at various tiers of health. So if you are expecting that now they're also going to do counseling, which is important, but if maternal morbidities is not considered as a big issue, as maternal mortality, neither will it get the budget, nor it will get the support for creating demand, or even budgeting for support for dietitians. A lot of dietitians that are coming out from various home science colleges are not linked to PMSMA, and we found it a huge difficulty to mobilize the home science and the dietetics community to work together to come forward with the private sector gynecologists as one unison for one agenda. So they, to moving out of their comfort zone, to come in the space to provide program support. In terms of leadership and governance, we see the overweight obesity agenda is missing, and management strategies, rightly so, because there are no clear answers. Even if you look at the work that we have done, we have not seen its effect on excessive weight gain and whether it has reduced. So research on management of overweight obesity at a public health level is not there. In terms of capacity building, we don't see maternal nutrition training, even half day, being a part of A&M trainings. If it is, then where are the trainers? Is it an institutional approach? We see that there is a huge scope, but the beauty is the intent is there, and little tweaks can be made to push it further. Suppliers, as already mentioned, if you just look at PHCs or CHCs or even BHMDs, weighing scales, how many of them are there? How many are functional? How many are even validated? Do we do a validation exercise frequently is a question. Institutional mechanism I really mentioned before. We have one National Institute of Nutrition, and that has now come forward to anchor the maternal nutrition agenda. We need more. We need at state level. We need at sub-national level also. We need at sub-state level also. And there we feel that there are over 1,000 odd nutrition colleges that can really play a role. Are they or are they not? What are the constraints and how they can be brought into the mainstream agenda as medical college is something which we feel is still a challenge. Now research, and that's where I think we all come in here, is like, several research is happening on GDM, but several development agencies. How about layering some nutrition interventions and seeing the effect size of change? What about those researches that are happening in health and wellness centers, which is supposed to provide counseling? Can different models be tested of either flipped cards, tele methods, bringing dietitians, minus dietitians, a combination of diet and physical exercise or more? We don't have that. And because we don't have that, and we are seeing the gray areas, we are seeing that the decisions on these efforts is now getting delayed. If we are able to address these systems gaps, as I showed in my previous slide, I am positive that the agenda on maternal obesity will move. With this, I also request my co-speaker, Dr. William Joe, to come forward and take on the next part of the presentation on maternal overweight and obesity based on NFHS 5.
Yeah, thank you, Dr. Vani. I will be over the next 5 minutes, I will try to quickly present some of the district level findings on the BMI cutoffs for women in the reproductive age groups. So as we all know that NFHS 5 fact sheet, it was released in December last year. But apparently that information provides only a few indicators for BMI, and definitely there is a lack of data on understanding obesity in pregnancy, and we have to wait some more time to get much more deeper insights to understand one-to-one associations. Nevertheless, this data is important as it gives us a sense of what is happening. For example, we know that child undernutrition and even anemia prevalence, there was a very mixed performance in the last 3-4 years. But in terms of obesity prevalence, overweight prevalence, there is an increase across districts, most of the districts. So that is something which is worrisome. Here, for example, we know that there is a greater concentration of high BMI cutoff prevalence in southern states. And for example, very relatively large prevalence is noted in Kerala, in southern part of Karnataka, in Andhra Pradesh and parts of Maharashtra and Telangana. Even in the northern states, I think for some more states data is still awaited, but overall we are finding that there is a consistent increase in the prevalence of overweight and obesity among women in the reproductive age group. So this is something which we have to be concerned about, because such improvements, if nutritional status is going in a single direction, then we are not finding such improvements among children, but there is a considerable skewed kind of nutritional status or weight gain which is happening. So that we have to understand what are the causes and what could be done to actually address this phenomena. Based on the NFHS different rounds, we just thought we can examine what is the trajectory of the prevalence of overweight and obesity across states. So for the 22 states and union territories, we have some data. Based on this, what we are finding is that the trajectory is actually very sharp for Kerala, for Sikkim, for states like Manipur, and in some states which already have high prevalence like Andhra Pradesh and Telangana, there is a flattening of the trajectory. So in some states, it's actually continuing to go up. If we project it for say the next 5 years or so, we are expecting that in Kerala, it will continue to increase given their past trends. But in states like Andhra Pradesh, it shows a little bit of flattening. Interestingly, in Gujarat, we don't see such a rise in terms of obesity prevalence, and such pattern is also noted in Maharashtra, where there is a very mixed performance because some districts are having lower prevalence in terms of overweight and obesity. Northeast states are also important. I think in some places that is also going up. In this particular spatial cluster, we are trying to understand whether the waist to hip ratio is associated with high prevalence of overweight and obesity. This indicator apparently is not providing very clear picture. And I think if we have to read the indicator of waist to hip ratio, it has to be taken along with some other indicator to understand its implications in terms of our understanding of nutritional status. This I will elaborate a bit further. So here in this one more slide, we are trying to examine if the districts which are having higher prevalence of overweight and obesity, that is if they are having more than 10% prevalence, are they also burdened with cases such as anemia and cases of hypertension. So I think anemia is widespread in the country. So there is no surprise that we are finding that all districts with high prevalence of overweight and obesity, they also have a problem with anemia. But we are also finding very strong association with the prevalence of hypertension. And it is also important to note that in all these districts, there is also high chances that the institutional births are happening mostly in the private sector. So that is also a critical component. And from a management perspective of obesity in pregnancy, this has important implications. Now we quickly just try to understand some of the associations which can be useful to interpret what is the meaning of rising obesity or overweight prevalence. So first case we notice is that if the undernutrition among women, which is like low BMI cases, if that is coming down, does it necessarily mean that the prevalence of overweight will go up? So there I think we are finding a very mixed picture here, in the sense that there is large variation. That is, for a given level of underweight prevalence, the overweight prevalence can be much higher or it can be even much lower. So there are districts which are having low prevalence of both underweight as well as overweight cases. So that is something which is very interesting, and one needs to understand why those districts are having such a relatively better profile than other districts. Again, as I had emphasized, waist to hip ratio does not provide a very consistent association. And that is something we have to be like understanding that why or which indicator can be taken to understand this relationship, because currently it doesn't show any relation. Apparently, as we all know, the prevalence of hypertension and the prevalence of high blood sugar level, which the NFHS provides, it gives a very close association with the prevalence of overweight across districts. It is a district level phenomena, and still very strong fit is noted in terms of prevalence of hypertension and diabetes or high blood sugar among women in reproductive age group. From another point of view of healthcare provision, 2 points are worth noting here is the districts where the overweight cases are larger or the prevalence is higher, we find that the proportion of institutional birth is very high in those districts. It's like more than 90% and in fact close to 100% in very high prevalence districts. So it provides us an opportunity to reach out to all these cases, especially because it can be reached through both public sector or the private sector, because they are accessing healthcare services for their delivery care. Even for the antenatal care visits, we see that districts where the prevalence of overweight is high, there is a high utilization of antenatal care. So that is also a very clear pattern which is emerging. So these things are encouraging from a point of healthcare utilization where we can feel confident that we will be able to reach out to them, but then we have to find strategies and what we have to do to intervene in this particular group. We also did some simple regression analysis to understand whether the district level prevalence of C-section births are associated with the obesity or overweight prevalence in those districts. And I think we find very strong association that if say the prevalence of overweight or obesity goes up by 1 percentage point, then the prevalence of C-section will increase even more than 1 percentage point. So there is a very strong correlation between that, and I think that is a concern. And we also note that in the southern states, the proportion of C-section is rising, which can be partly attributed to the rising prevalence of overweight and obesity also. I think most of us try to associate overweight and obesity prevalence. One is with the demographic factors, that is with the rising age, but the other important factor is whether dietary intake is also making some difference. We find that in fact there is a variation, although the quality of dietary intake data, I think that is a challenge still to understand the national picture. But even whatever data we are finding from NFHS, it is apparent that there is a greater consumption of various food groups among those who have a higher BMI cutoff. And there is clear gradation between those who have higher BMI and lower BMI in terms of their dietary intake. So some of the food groups are actually consumed more among them. So given the paucity of data in terms of the dietary intake, I think that is a major gap where we are not able to understand what is the income level of the household or consumption expenditure level, how much they actually eat, and what is the outcome in terms of their anthropometric outcomes. So these three we are not able to still study for the country as a whole, although we have like studies from different areas. But given that, I think here apologies for not being able to show you the cell range because of I think compatibility issues, but this analysis of dietary pattern, consumption pattern, actually it is trying to highlight that our diet has been shifting from a cereal-based one, prominently cereal-based one, which is the deep orange color. And over the say course of 20-25 years, we are although consuming less of cereal for our calories, but in terms of our sugar intake, in terms of our intake of fat related products, it is actually increasing. So given that tendency, we are finding that in India, as we are like growing, as incomes are increasing, our protein and calorie intakes are actually not going up much, but what is actually increasing is the average fat intake, which is substantially increasing both across the rural and urban areas. We had done some analysis based on the national sample survey data, just to add to the limitations that we don't have much better quality like nationwide data to understand this. What we are finding is that the elasticity of consuming fat is much higher than consuming protein or other food groups. So that is very important message that we have to understand why mostly our calorie intake is now moving towards a fat rich diet. In fact, if one can quickly understand the projections around this, what we did was we tried to examine what are the patterns in terms of our calorie, protein and fat intake. And we find that if we will proceed in the same pattern as what we have done in the last 20 years or so, our fat intake is not likely to slow down in near future. In fact, it is likely that our fat intake on an average will keep on increasing because the elasticities are still very high. And it will not stabilize like usual calorie intake, which will be stabilizing in the next about 10 to 20 years for rural and urban areas. But I think fat intake is something which will go on increasing, and that is very strongly related with our overweight and obesity prevalence across country. So that is something I think we have to work on in terms of policy. And I will now request Dr. Vani to kindly take over from here for the final message. Thank you.
Thanks, William. Colleagues, our 5 take-home summary messages for you. First, nutrition assessment. You can continue putting on full screen, yeah. Nutrition assessment, at least gestational weight gain, based on gestational weight gain, even if pre-pregnancy BMI is not available, and its related counseling and tracking, at least be prioritized with. We have that available in the RCH register, but we don't have that moved up onwards for in HMIS. Nobody asked for it, nobody does it. Based on the gestational weight gain, counseling be provided, and that also be recorded and tracked, because it is diet and physical exercise related individualized counseling that makes a difference. We feel that the 5 actions that we've been working on over the past 4 or 5 years very well aligned to the FIGO checklist, which I know will be shared in a bit. And these 5 points of assessment, giving micronutrient supplements, counseling based on gestational month, simple 1 message, 2 messages for that month, classification of those risks, and additional counseling based on the risk at each contact needs to be done and tested for effect size or change on excessive weight gain. Broadly, we feel diet and lifestyle modification matters. How much it matters, for how long and what generation. We don't have so much of data on maternal obesity management in hotspots at large scale, which need to be done. If you look at take-home ration and those providing cereal-based hot cooked meals or double ration, specifically in geographical areas, without looking at the burden of overweight obesity, we feel it may lead to even the situation that is going to be there in Sri Lanka, and hence the quality of the take-home ration should be nutrient-rich and not just only calorie-rich. At the same time, we feel that counseling needs to be backed with regulations on the food environment and preventing the food security entitlements to do more harm than good, as I mentioned. The regulatory mechanisms needs to be studied, and what is really being done by the food regulators also for creating mass awareness needs to be evaluated, else there'll be different people, lots of efforts without knowing whether it's leading to any change or not. And hence, our final message is, in the portion of Beyond, there needs to be an overarching framework, not only for gap assessment, but also for monitoring and tracking programs for management of maternal overweight obesity. Thank you very much.
Thank you, Dr. Vani and Dr. William, for that brilliant presentation. Now we will move on to our next presentation. It's my great privilege to introduce Dr. Marie-Laure Frolot for the next session. She's a pediatrician specialized in nutrition and childhood obesity, currently holding the position of Deputy Chair, Clinical Care Committee at World Obesity Federation. She is the founding member and the past president of the European Childhood Obesity Group. She spent most of her career in Paris Children's University Hospitals. She is also a founding member of SCOPE, which is World Obesity Federation's Committee for Teaching Obesity. She has recently won the French Academy of Medicine's Nutrition Award. Dr. Marie will tell us about what India can learn from the global action in tackling obesity across life stages. We welcome you to our webinar, madam. Please take over. Thank you.
So thank you very much for your invitation. I'm very honored of it. Now I need to find how to show you my slides. And and I have to think to go there. And please let me know if you see my slides properly. Is it fine for you?
Yes, ma'am. We can see you.
Okay. So the topic I was asked to debate is what can India learn from global action in tackling obesity in pregnancy? And in fact, for doing that, we need to keep in mind that what's behind this need of early prevention is the idea that everything starts really even before pregnancy, because the environment will have a strong action of the expression of the genes of the mother and the child. And this impact on the genes and their expression, which is called epigenetics, will be transferred from generation to generation from mother and father. But the good point that, the optimistic point of that, is that environment can be modified. And that's where we have to try to tackle some good point to protect women and children. This environment can be understood as nutrition, physical activity level, smoking, stress level, endocrine disruptor, pesticide, etc. So there are a lot of things we have to pay attention to. We also have to keep in mind that obesity is a disease, and it's a chronic mild inflammatory disease. And with this background, we better understand why cardiovascular risk level will be increased in pregnant women, and why there will be vascular consequences on early child development. The complications of obesity in pregnancy are targeting both mother and child. For mother, there are the classical complication of cardiovascular level, but there are also things one does not think so often too, such as sleep disorder or stroke. And one important point I'll turn back to is postpartum weight retention. The consequences for children can be dramatic. It ranges from fetal death to congenital malformation. And in terms of body weight, we have facing two opposed situations. One is that obesity may lead to macrosomia, while it may also lead to low birth weight. All these consequences are likely to last during all the child and then adult life. On this slide, I would like to show you how it is important to look at the weight gain during pregnancy, since this weight gain will tend to remain over life and then to lead to a definitive obesity level in the women. And as you see from this slide, this may start even in underweight women. Of course, the more the woman is overweight or obese, the more she is likely to add weight to excess weight. And the more she is obese at the beginning, the more all other complication levels will increase. The relevant factors that have to be tackled for obesity prevention classically started at conception. And you see there a presentation of classical action that are intended. We now know that it is extremely important, in fact, to start before conception. So it's a general improvement in quality of life and eating pattern and moving pattern that should be looked at. On this slide, I show you data from my own country, where fortunately maternal deaths during pregnancy are low, but I was struck by the data here, who show that any severe condition before pregnancy may increase by 10 the risk of death during pregnancy. I mean, starting from delivery to 1 year after delivery. And this risk is really directly proportional of the degree of overweight or obesity. As you can see here from this data, if level 1 is for women of normal weight, it may reach 3.5 in women with class 3 obesity, with strong obesity. On this slide, I would like to draw your attention to what I found interesting, which is a way to improve the way to use diet in order to prevent obesity at whichever is the situation. Sorry. Instead of only looking at the amount of food of variety of food, in several studies, the food were classified as other food with low inflammatory index, or as food which may help preventing hypertension, as shown here. Using this classification of diets, 7 European mother-offspring cohorts were studied, and what could be shown is that really a low inflammatory diet would lower the risk of low birth weight, while a diet with a good profile for preventing hypertension would help having a baby of normal or good birth weight, while, as you know, hypertension tends to lead to small for gestational age babies. So let's now enter directly into the topic and look at different data we can find on the web about the impact of studies around the world. I think I went too quickly, that's fine. In a very quite late study published in 2013 could find that in developing countries, the risk of having a problem with a pregnancy was linked to low energy intake, low protein intake, which would lead to a greater risk of obesity among offspring. So keep in mind that the impact of under and over nutrition, as was previously presented by the previous speakers, is tightly linked. And an important point too regarding the body composition of women that will be childbearing is that if themselves had a low birth weight, they may have then a greater fat mass as adults. In this first study, which was systematic review and meta-analysis, most recent one, 20 trials, including a huge number of women, tried to look at the outcome for children between the age of 1 month and 7 years in 10 countries from Europe, the States, Australia, and New Zealand. And this study looked quite disappointing because it did not find apparently any significant association with child measurements and the lifestyle intervention in their mothers during pregnancy. However, I think that we have to be cautious about the validity of such studies who are mixing people with different background, different techniques of intervention, and even if it is officially presented as a gold standard of randomized controlled trials, anyway, it may not be that significant in terms of quality of the program behind. That's why I find it much more interesting to look at data about studies that focused here on the impact of exercise during pregnancy and their impact on the risk on preterm birth in overweight and obese women. Here, as you see, this exercise program was proposed before 25 weeks of gestation. It was aerobic exercise, 30 to 60 minutes, 3 to 7 times per week. And of nine studies have been included in this meta-analysis. The countries are from South America and North America and Europe. And as you see here, the author did not identify any difference in terms of birth weight, low birth weight, or macrosomia, but there was a dramatic decrease in the risk of diabetes mellitus using this strategy of physical activity only. Another study in the same state of mind looked at pregnancy, at the impact of the same pattern of physical activity in women with hypertensive disorders. These women were or were not obese, but the common point was to have high blood pressure. And what you can see here is that it's extremely efficient in terms of reducing the degree of hypertension, and it was extremely efficient in terms of reducing the number of cesarean delivery, since it falls down by 16% in the exercise group. Another meta-analysis, and I'm sorry to present meta-analysis because there are so many studies that we now have to use these studies of studies, try to look at the impact of lifestyle intervention to reduce the risk of gestational diabetes in women. And this lifestyle intervention managed to reduce the risk by 15 to 40%, with a mild impact on weight gain and with a stronger effect of exercise above the impact of diet alone. Another trend of intervention tried to look at the impact of the combination of intervention designed to limit gestational weight gain. And in this case, the weight reduction was not that strong in all pregnant women, but the impact of on decreased adverse neonatal outcome was very, very strong, and especially in reducing birth defects. I would like here to, and of course it had a strong impact on gestational diabetes mellitus, which it managed to reduce by about 1/3. I would like to draw your attention to something which we can start seeing now. It's young women which have been operated by bariatric surgery before pregnancy. And in that case, of course, there is a strong reduction of diabetes, but there are huge problems with small for gestational age rates babies, risk of preterm birth, or overweight babies. So this is a dangerous condition, and these women will have to be followed in a specific manner. In this study here, obesity and weight gain were reviewed with reference to lifestyle intervention designed to inform maternal and child, and to inform, mother about the benefit of a better health. 15 studies could be used in this analysis, and women were belonging to all BMI classes. The overall conclusion is again that the impact on gestational weight gain was not that high, as you see. It's very, very modest impact. But then when looking at the risk level on gestational weight gain above international guidelines, or at complications of pregnancies, at complication like cesarean section, problems in the newborn with respiratory distress syndrome and macrosomia, you clearly see a significant impact on all these aspects. And the conclusion here is that multi-component approaches, including a balanced diet with a low glycemic index, had and in association with light to moderate intensity physical activity, was quite efficient, and should be one way to try to prevent complication of obesity in women. My last slide will draw your attention to the fact that after pregnancy, there is a possibility to breastfeed or not to breastfeed the baby, and that baby should be as much as possible breastfed. From this data in Europe, which is data from a study called FOGSI, which was intended to reduce the consequences of and prevalence of childhood obesity, we could see that among children aged 6-9 years, the fact of reducing, of having been breastfed at least 6 months could reduce the risk of being an obese child by about 20%. So my conclusion to this short presentation is that evidence arises from current understanding that obesity and pregnancy complication and outcomes are tightly linked, that prevention studies are of course necessary, but must fit individual profile. There is no, and obesity, there are several profiles or patterns of obesity development, should start in pre-pregnancy or early pregnancy and last during postpartum. And this prevention study should try to focus on a combination of physical activity and diet. Diet should be safe, balanced, try to decrease pro-inflammatory nutrient and increase in protection against hypertension. And physical activity should of course be moderate, regular, several times per week, but adapted, of course, to the stage of the pregnancy. Of course, these prevention studies should be evaluated on both maternal and child outcomes, which is not yet the case. Many studies do not look enough at the consequences for the child, and of course be followed by incentive to breastfeed. I invite you to look at the free ebook on childhood obesity that may bring you further information. And I invite you to look at scope modules on childhood obesity that will bring you also other complementary information. Thank you for your attention, and thank you for inviting me again.
Thank you very much, Dr. Marty. That was a very interesting and there was a small issue with the slide share, I think, but we were able to get what you were saying. Thank you very much, ma'am. Let's move on now. Yeah, we'll be starting our panel discussion now. I am very happy to introduce the moderator for panel discussion today, Dr. Hema Divakar, a very dynamic personality who is the medical director and at Divakar Specialty Hospital. She is also the CEO and chairman of ARTIST. She's a senior consultant, obstetrician and gynecologist with over 3 decades of experience and expertise in women's health care. She is the vice chair of FIGO PNCD committee from 2015. She has many awards and recognitions to her credit. To name a few, FIGO Women Achievers Award and Excellence in Women's Healthcare. So over to you, ma'am.
Namaskar. Thank you very much. And with my respects to Prema ma'am and my heartfelt thank you to the three lovely ladies, Bharti, Rajni and Vani, who are responsible for bringing us all together on e-dialogues month on month. We are going to be going on a fast track on our panel discussion because we have such distinguished panelists who in their own individual and organizational merits have accomplished so much that just imagine that if all of us work together, how powerful and how strong the implementation strategies and the impact will be. We have with us today Dr. Somesh Kumar, whom we had the pleasure of working when he was at Japago India office. He's now the Senior Director of the New Initiatives and Innovations at Baltimore and is the Program Director for International Education in OBGYN. His strength is implementation of transformative programmatic processes using the technology solutions and innovations. Whilst we wait for Somesh to rejoin us back, we have great pleasure and privilege in introducing to you Professor Fionnuala McAuliffe from Ireland, whom I had the good fortune to meet as a member of the Pregnancy NCD Committee at our international organization, FIGO. She's a professor and chair of OBGYN at the University of Dublin, National Maternity Hospital at Ireland, and the director of UCD Perinatal Research Center, School of Medicine. Most importantly, led by her, FIGO has launched what we call as a PONI initiative, PONI, expanding as pregnancy, obesity, nutrition initiatives with the FIGO checklist aligned to our government checklist, which Fionnuala will show in her presentation. Girdhar Babu is the professor and head of life course epidemiology at PHFI, MPH and PhD in epidemiology from University of California, Los Angeles, and former research associate for multicentral AIDS cohort and special reader at the UCLA as well. He's edited the guidelines for health professionals for prevention and management of NCDs in primary healthcare settings of our state, Karnataka. We have great pleasure in inviting as a distinguished panelist, Dr. Neena Bhatia, who is a senior specialist at Niti Aayog, New Delhi. Ma'am, I'll be beginning with our panel discussions with you, and then Fionnuala will take it forward with her short presentation. Neena ji is the associate professor at the Department of Food and Nutrition, and she's technical advisor for NCERD at the Lady Irving College at New Delhi. And key areas which are interested us today are her key areas of interest and work as well: the public nutrition, diet counseling, and epidemiological research work. And she's developed the computer software for nutrition counseling, the finest use of technology, which would come to our rescue in reaching the unreached. And last of all, we have Ms. Inoshi Sharma, who is leading the Eat Right initiative, as Vani has said. She's the director, Social and Behavioral Change and Communication, Fortification Research Center at FSSAI, Delhi. Last but not the least, clinician on board, Dr. Naval Kishore Vikram. He's a physician, diabetologist, and the professor at the Department of Medicine, AIIMS, New Delhi. And his research interests again revolve around the topics that we have been discussing in the last hour or so: obesity, body composition, metabolic syndrome, atherosclerosis, type 2 diabetes, non-alcoholic fatty liver disease, and so on. And recent awards as Young Scientist Award, and we are happy to have the youth leader on board. So with that, we plunge into the discussion with Neena ji first, because I just quickly checked with her whether she has any slides to present. She said no, she will just speak to all of us as is. So Neena ji, one of the front runner which has caught everybody's attention in the country is the Poshan Abhiyan. Until now, probably we had not paid the much needed attention to the nutrition. So can you just share with us your experience in paying attention to details matters? Okay, and the micro details were paid attention to. I'm aware of that in the Poshan Abhiyan. So what were the implementation strategies that the Niti Aayog suggested, and how could we collaborate and connect to take this to the masses, to get it off the ground in the manner that it's required? Neena ji.
Thank you so much for having me here. And, I really appreciate this work that we started about 3-4 years ago together, and the trends over here on overweight, obesity in maternal nutrition that Vani and William and, other speakers have presented. When we were developing these guidelines, I still remember going through, trying to look for evidence, and we really lack evidence on that. So I'm very glad that this work is taking shape and now moving forward. So thanks to the organizers for having me. Now, of course, Poshan Abhiyan, talking about it, is the overarching scheme, on holistic nutrition launched by Honorable Prime Minister in March 2018. So we are just about, 3 years, completing 3 years of the Poshan Abhiyan. And this is an overarching, flagship scheme of the government of India, which, basically relies on multi-sectoral convergence, and it is on various programs, ICDS, from the, WCD, then health programs like for young infant, HBNC, HBIC, Anemia Mukt Bharat, and basically it tries to tackle maternal, infant and young child nutrition. The focus was on first 1,000 days as it was launched, and trying to reduce low birth weight, trying to reduce underweight, trying to reduce stunting and anemia. And it had very specific time-bound targets for 2% reduction in all the parameters except anemia, where it was 3% per annum reduction that was targeted. And the key essential elements, that were listed out in National Nutrition Strategy of Niti Aayog, which was released in 2017, were incorporated into this flagship program, which talked about delivering high impact interventions with adequate coverage, continuity, intensity, and quality, what we commonly call C-square IQ, and then also there was a lot of focus on behavior change communication at scale, and using technology, for reaching out to the people, tracking the progress of undernutrition, and adequate financing and monitoring mechanisms, and committed leadership and enabling environment. So with these 5 key things: convergence, technology, increasing the reach of the schemes, and with committed leadership, convergence, this scheme was launched to impact malnutrition. And as Niti Aayog also has been mandated to carry out its 6-monthly progress monitoring reports. And we have been looking at the program with great detail, and now with NFHS 5 data being released from 5 states, we can clearly say that India's malnutrition challenge is really stark, and of course there are improvements in many things, so we should but anthropometry, child anthropometry somehow is not showing that progress that we would like to see. So there are positive stories from certain states like Bihar, which are encouraging, and there is also improvement in exclusive breastfeeding and adequacy of diet among children. But there is worsening also of certain things like early initiation of breastfeeding, timely introduction of complementary feeding. There is improvement in many health indicators, services, I would say. Immunization, ANC checkups particularly have improved, and also there is underlying parameters, social and health indicators, water, sanitation, women's education, early marriage, all affect finally the nutrition.
So
and now
Ninaji,
India, Yes.
Yeah, Ninaji, my key question to you when you're mentioning this multi-sectoral, comprehensive approach, that is the vision, in fact. So we are all working in silos all the time, and this is one of the rare occasions where we've come together on a platform. So I want to know from you two little things. One is, where is the start point of the 1,000-day mission? And how the mother and child care itself, it's so aligned, but it's still so different. The pediatricians and the stage, child is child, mother is mother, and it's a disconnect in a way. And today we are talking about the NCD as a far-reaching implication of what happens to the programming in the womb. So when we can't even link in the first 2 years the mother and child initiative of 1,000 days, how do you kind of foresee or envisage the linking of the mother for the rest of her life and the offspring of this mother also for a continuum of care? What is the kind of micro planning and the strategy as the Niti Aayog component? How do you look at that?
Yeah, so we are trying to, of course, the starting point, it's like the egg and the chicken story, but definitely we are starting with mother's pregnancy, though ideally would be to start from adolescents or the women in reproductive age and newlyweds, but definitely there is a lot of focus on pregnancy care, and that is why I think this today's seminar also is very important. And the triple burden of malnutrition, that affects, now we know from NFHS 5 data further that how India has both to deal with undernutrition as well as overnutrition and micronutrient malnutrition. So the program actually is in the progress that we have made so far is in terms of the interventions that were specific to this program in terms of growth monitoring not being happening on the ground. So, trying to have the equipments, trying to have the smartphones, trying to use the technology to monitor. Are now our monitoring shows are now have reached, and now the next step, Ocean 2, is what we should all aim for, and it has to expand its vision from, of course, to tackle the malnutrition, or the triple burden of malnutrition. And there is a lot of focus on fortification, particularly for anemia. There is a lot of emphasis on increasing the coverage for Anemia Mukt Bharat with our, with the Ministry of Food. We are now testing rice fortification with iron, folic acid, and B12 across various districts, and FSSAI and various partners, are supporting that, and we are very keen to take it to a large level. Also, simultaneously, there is a focus on newborn care. HBNC, that is very important component, though it comes from health. So the challenge of Poshan Abhiyan, that challenge that it is trying to take is a difficult challenge of converging various ministries. But what we have seen over a period of time, that even yoga, Ministry of Ayush, then fortification, then Nutri Gardens, then, various ministries are coming forward, and that thing, it is like moving in the right direction. We need, with COVID, unfortunately, there were, disruptions, and now, but we can see, but however, that the supply or things, interventions have improved to a pre-COVID, mostly to the pre-COVID levels in most of the places. And now is the time to give it a fresh push. And that is what Niti, will be really working towards, and focusing on taking these forward. And the large focus has to be on the demand side also, supply side as well as the demand side barriers. And particularly behavior change. Even if, because our programs unfortunately map, like how many days the IFA tablets were given, but not for how many days the IFA tablets were actually consumed. So we have to really work on that, making sure that interventions are really complied with you know, and there will be Niti is particularly trying to engage with civil society organizations, with you know, various stakeholders at the field to really make it a Jan Andolan.
Absolutely. Thank you so much, Neena ji. Thank you so very much, because you have given us hope that we have begun right. We will stay together and stay on track. Fresh thinking and new frontiers is what you are saying about the linkages which is waiting to happen, and this is perhaps a great start for that. Thank you so very much. And we now have Fionnuala to make a presentation on what FIGO, PNCD Committee Initiative, has been saying. Think nutrition first. As we have just said, thinking process has to begin first, waiting to be translated into action. And at the key points, pre-pregnancy, pregnancy, and post-delivery, there are some very specific guidelines from FIGO that we are taking on board in the Indian context and sensitizing all the OBGYN community through FOGSI and artists throughout in the last couple of months, and our unfinished agenda also continues. So we present to you, ladies and gentlemen, Fionnuala McAuliffe from Ireland. Fionnuala, all yours.
Thank you, Hema, and thank you for the very kind invitation to speak. And what we're going to just briefly review in the next couple of minutes are what FIGO is doing in terms of guidelines. And the scene has been very nicely set by Dr. Sethi and Frelush in terms of what the magnitude of the problem is. So we in FIGO feel that obesity and nutrition is really a very high priority, and we have recently launched the FIGO Pregnancy, Obesity and Nutrition Initiative. Our vision is nutrition and weight are at the front line of pregnancy care for women globally, and our action point is think nutrition and weight first at every contact. We will achieve this through guidelines, practice resources, advocacy and training, and we are rather ambitious, but we really want to focus on giving the gift of a life free from non-communicable diseases. And I think we all understand what that means, having just heard there from Dr. Bhatta and also Dr. Freelit in terms of the intergenerational effect that nutrition and high BMI has on the next generation. So we launched the PONY initiative in 2018 and had a supplement in the International Journal of Gynecology Obstetrics in 2020, just last September. There are 7 articles covering many of the issues that we have heard, together with one from India as well. So we're just going to briefly review the guidelines. So as you know, there are guidelines throughout the world on the management of pregnancy associated with the high BMI. So what we did is we brought together all of these guidelines, hoping to consolidate recommendations from all of our member countries. As you know, FIGO is an international organisation spanning 138 countries worldwide. And we're hoping that these would be useful to any healthcare providers working with women living with obesity, and governments and healthcare organisations. So there are 3 time points. We've heard already how important those 3 time points are: pre-pregnancy, early pregnancy and postpartum. So pre-pregnancy, we have a number of guidance around height and weight and body mass index being measured, considering ethnic differences. And I note that from the talk from Dr. William Joe, that BMI over 25 in India is considered to be a high risk BMI, whereas in other parts of the world it's 30. Women should be encouraged to lose weight prior to pregnancy, and crucially to take folic acid up to 3 months prior to pregnancy. In terms of pregnancy, we have many recommendations, as you can imagine, around gestational weight gain, and we heard a lot of data about that already from Dr. Freelut from the World Obesity Federation, and appropriate diet. And really crucially, that last point there is that we really need to look at our antenatal healthcare facilities. We need to have multidisciplinary care pathways for the management of women, such as a larger cough, considering aspirin to reduce preeclampsia, screening for GDM, VTE prophylaxis, and monitoring the fetus carefully, because of course fetuses whose mothers have a high BMI are at greater risk of stillbirth. And then postpartum is really an opportunity to review the pregnancy and to think about perhaps interventions prior to the next pregnancy. We've heard about diet and exercise, where appropriate and if available, bariatric surgery. And of course, we need to consider maternal BMI when prescribing postnatal contraception. So that's just a fly through the guidelines, and they are available on the website. But many healthcare professionals say to us, look, we know it's important, but how do we get the conversation going? So we at FIGO have developed the FIGO nutritional checklist. And the first step is to identify special diets, then to calculate body mass index, as we've heard. And then looking at the quality of the diet, we have 6 questions and asking them, have they eaten the following in the last week? And ideally, they would have a number of portions of these per day or per week. And then finally, looking at those crucial micronutrient factors, folic acid, vitamin D, and iron. How does this FIGO checklist, how would it translate into India? Of course, India is a very large, diverse country with many different cultures and eating habits. But certainly for those that are vegetarian, the meat, chicken, and fish questions could be replaced by pulses and paneer. So looking at the FIGO checklist, of course, this is just one checklist, but it would be translatable across in India. The checklist has been used in Hong Kong, it has been used in Italy and in Ireland. So we encourage you to look at these resources, download them, change them for your own uses, translate them into your own language, as has been done in Chinese, and really think about nutrition and first at every contact. And thinking when you see that pregnant woman, we want to give her the gift of a life free from non-communicable diseases. Thank you.
Thank you so much, Fionnuala, for that crisp and a brief presentation. My thoughts go back to the fact that, yes, very simple and straightforward, practical and pragmatic checklist has been drawn by FIGO. What to your mind appears that these simple little things, why do you think the clinicians were not doing it before? Or even after the checklists have come in, what is the scenario in your part of the world as well? Or are we the only ones who are still to catch up? Or some of your research studies show that there's not enough being done in many parts of the world. And why do you think so? And how would you make the supply side stronger? Whilst I park that question with you, we would be inviting Inushi Sharma next, because Nina Bhatia already talked about the demand generation. This is all between supply and demand. So if she generates a lot of demand from the market and they come to the healthcare providers at any level, then we should be doing some quality work which will have an impact and make a difference. So what are your thoughts on that, Fionnuala?
So we've looked at this, and the barriers are that doctors and midwives don't feel confident to have this discussion. It hasn't been covered in their midwifery and medical training. So that's one barrier. Number 2 is they don't have enough time. So the idea of that FIGO checklist is it's one page, the woman fills it out herself, and on the back side of the page, there's the advice that the healthcare professional can give to the woman if she says, no, she's not eating whatever food or whatever. So the idea is that it's a one page that the healthcare professional has the advice at hand. So we did some qualitative work on it, and the women, found it easy to fill out. It was very useful, but it was most useful if the healthcare provider actually went through it with them. So one of the things we're looking at really is looking at our medical and midwifery education. I mean, everyone talks about, diet, lifestyle, etc. Nobody knows how to address it. So these are the things that we're looking at as enablers. And I suspect these points are the same the world over, whether it's low, middle or high income countries, we all seem to have this challenge.
Yeah, thank you so much, Fionnuala, especially because you have taken so much time not only to be there as a distinguished part of this panel, but I have seen your presence throughout the deliberations of this e-dialogue, and we much appreciate your participation and would welcome your inputs even going further, because when we disseminated this, we are still on a massive mission on disseminating this. At the end of it, everybody, they thought, FIGO, checklist, will it be doable? And then they say, it's so simple. Why haven't we been doing it before? So I think this will escalate sooner rather than later, and we'll promise to get back to you with some more concrete data and move ahead with some more meaningful discussions. Thank you very much, Vinyala.
Thank you.
So we, as I said, go to Ms. Inoshi Sharma. Eating right is the mission. We just heard from Vani, and there was a question in the chat box as well. What explains the obesity in poor people? Because they said that there's so much rising obesity even in the rural India. So maybe they're not eating right. And that's the key to Inoshi Sharma's deliberation, after which I want to pose a question on how do you generate demand? Can you get directly in touch with the consumers to help them change their mindset, their attitudes, their lifestyle, etc., on the eating right mission? Inoshi, please.
Thank you so much. And, you know, with the Eat Right initiative, actually, FSSAI really wanted to lay emphasis on, you know, how important it is for the regulator not just to, you know, be the apex body which is taking care of the food regulation, but also bringing about a change in the way people actually perceive food, and they are I'm so sorry, I just moved. There was too much you know, background. Okay. So what really the FSSAI wants to do through the Eat Right initiative is, you know, create this awareness among people that how important it is to eat right at every stage of your life. And nutrition is something that is most commonly not understood properly. What we really want to say in the Eat Right initiative is, why do we need to eat a balanced and a nutritious diet so that you do not end up with NCDs, you have a health which takes care of you, you don't fall ill. So through this little presentation, I want to talk about what the Eat Right initiative is and how through this initiative we are tackling various aspects of, say, NCDs, maternal obesity, any kind of issues which are related to health. So next, please. You know, we've got the NHFS 5 data, which has come out recently. We've also got the CNS report, which came out in 2019. And what we've really found out is, you know, a large population of women and children in our country are anemic. Children are anemic, and it's putting a huge burden of almost $12 billion in terms of our GDP. And also, when you take deaths in India, 6 out of 10 deaths are related to NCDs, which really means that it's your diet which is actually causing this. And it's something which can easily be taken care of. Next, please. So what FSSAI really does is ensure safe and wholesome food. So we prepare food standards, safe practices. We've got a whole setup of labs which are doing food testing. We've got food compliance. We've also got training and capacity building. Next, please. But what we realized was that was not just enough. You can have all these things in place, but even then, it does not guarantee that people are eating healthy, nutritious food. So what we really thought was come out with the Eat Right India initiative, which the Eat Right India movement, which we call, which is based on 3 pillars: eat safe, eat healthy, and eat sustainable. Next, please. Now, eat safe primarily is based on the concept of ensuring personal surrounding hygiene. Now, why we really emphasize this, because even if you're having nutritious food, but it's not prepared in a hygienic manner, or you are having food without washing your hands, you might fall ill. You may end up with a foodborne illness. You may have parasites in your gut. And that actually prevents the absorption of the nutrients. So that is why it becomes extremely important that the food that we're eating does not have any form of adulteration or toxic residues. And then we also lay emphasis on eating healthy. So diet which is not only good for the palate, but also for the body and the mind. So you have timely and less food, because a lot of us tend to overeat without even realizing it. Have a diversity of food, eliminate trans fat, reduce the consumption of salt, fat, and sugar, and eat fortified staples. Now, this particular concept is extremely, extremely important for women who are expecting, for lactating mothers as well, for adolescents, right from adolescents. If this is taken care of, further for women particularly, the issues that they face later can be met out. And eating sustainable really means is what we are eating, is it good not just for us, but also for our planet? So what we really talk about is eating local and seasonal foods so that it reduces the carbon footprint of food which has traveled great distance. Ensure that there is no food waste. Try to recycle the food which is left over. Reduce the use of plastic. Try to recycle that. Conserve water and reduce chemicals in the food chain. Next, please. So maternal obesity is, of course, something that we've all been talking about. And I've put here the NFHS 4 data simply because, the NFHS 5 is only related to 22 states. But what we've really found out is because of the increased risk throughout pregnancy, the mother gestational diabetes is there, hypertensive disorders are there, the complications are there. This leads to increased complications during labor. And of course, all these issues are something which can be tackled just by diet. If diet and regular exercise is followed, these issues can be checked. Next, please. So what we really want to do through the Eat Right initiative is try through social media, try through various forums, try through our consumer organizations, our various stakeholders in society. We've got an organization called the NetProfan, which has 7 associations of doctors, nutritionists, food technologists, chemical analysts, public health specialists. Even chefs are there. We've got all of them together to talk to people about the importance of nutrition. Once we have taken control of nutrition, most of our issues are taken care of. For pregnant women, what becomes really important is iodine, folic acid, iron, B12, and vitamin D. And these can all be taken care of very easy by having a multi-staple, fruits and vegetables, and of course, fortified staples. Next, please. So what we did was, in association with the World Bank, we created this wonderful little video, which the Ministry of Health, of course, has been playing in all its health and wellness centers. It's the first 1,000 days. And why it is important, right from the time of conception till the time the child has been weaned off, to ensure proper nutrition. And what we've tried to do is not just have a video like this, but also created a toolkit, which we have given to all our ASHAs and the ANMs. And soon we will be sharing it with the WCD, the Women and Child Development Ministry, so that the frontline workers are aware of this importance and they can further disseminate this information among the public. So we've also got, during Poshan Ma, a large number of, webinars, we've got articles and blogs. But what we've realized really important is conversations in forums such as these, of course, it's really good. But how much of it is actually reaching the common man on the street or the common woman on the street? Do they get to hear these kind of conversations? No. Where do they get the information from? From the frontline worker. And that is why it becomes extremely important that we tap this particular workforce that we have. Next, please. So that was just from me. I just wanted to highlight the work that Eat Right initiative has been doing. It's multidimensional. We never really advocate any kind of a diet. We never really advocate a particular section of the population. What we try to say is, everybody please have wholesome, nutritious food, reduce your intake of salt, fat, and sugar, eliminate trans fat, and that will take care of your health. So thank you so much from me.
Thank you. Thank you so much, Inushi. Eat right also means start right, if you would agree on that. So do you think starting right at the adolescent age group is also equally important, since especially you talked about the social media outreach? Because we figure out that the adolescent population, the youth of the country, seldom are in contact with the healthcare providers. They love to get their information online and very little from their own peers, but not from anybody like ourselves. So just yesterday, Dr. Mark Hansen from Southampton, who is the vice chair of the FIGO Pregnancy NCD Committee, we were in conversation with the GAIN Alliance, Alia Poonawalla. And then they asked me whether I've heard of Eat Right, and it was because of you that I had heard of Eat Right. So I immediately put my hand up and said, yes, I've heard of it, but I have to do something about it. So just can you tell us the vision of your organization on the aspect of reaching the young population in our country through the digital technology.
So what has really happened with, in fact, the corona and the lockdown, because we've suddenly realized this amazing potential that we've got of the digital platform. So initially, I think after March, for almost 3 months, we were really focusing on health, hygiene, washing habits, surrounding hygiene, and generally those aspects. But subsequently, we realized that there's such a big dialogue which is going on social media about nutrition, about immunity, about diet, and all of a sudden these words which we were trying to promote was something that people were demanding. So we had this entire debate of what kind of foods to eat, what kind of kara to make, what kind of herbs to have, which are going to, improve our immunity. And that's exactly when we realized that, we need to develop these short videos which we can, disseminate through the social media platforms. Like you've got MyGov, you've got our own social media platforms. And we created a whole lot of videos. Now, what we are now going to do really is push them out. So for instance, recently what we've done is we worked with the Kendriya Bhandar and NAFED to promote double fortified salt as well as fortified rice in Delhi NCR, because they were not available in any of the shops because of the lockdown, but because of things opening up. So in March, particularly, you'll be seeing these Kendriya Bhandars and NAFED shops being stocked with these fortified staples. Now, what we are really hoping is once a demand comes and we are able to monitor how it happens in Delhi, we'll push it pan-India. So slowly and slowly, we are trying to do these programs. And like you said, adolescents are, they have the biggest potential. And we have an amazing regulation. The FSSAI came out a regulation for schools in July 2020, which prohibits the sale of food which is high in salt, fat, and sugar within the school and 50 meters around the school. And that is again something that we will be, once the schools reopen and students get back, take a feedback. How do they think? What do they have then as an alternative? And then really push these programs forward.
Excellent. I think this has been a brilliant input, and we much look forward to implementing all those we have spoken about today. And, the adolescents of today, the time really flies, and they'll very soon be potentially entering their reproductive age and embarking on their pregnancy, etc. So I think we should really, really catch up on reaching them through the best available means and beyond the geographies and reaching the unreached, and also parallelly strengthen not only the supply but also availability of alternatives of all that you said, and implementing the school initiatives of actually providing the right kind of diet, because it is maybe more easily said, but the children may hide and eat something else everywhere. So there's a lot. And the last point I wanted to also raise in the closing conversation with you is we have to have some mechanism for the follow-up of these, because so many videos are going out and so much information is going. Maybe we will also succeed in making the alternatives available, but are they integrated in terms of, does it really change the behavior, or it is just see and go? So that is again something that we will have to in a focused and a strategic manner work at. So we will definitely touch base, and together we will and we can, is what we believe. Thank you, Inoshi.
Thank you so
This
much.
brings us, when I said adolescent today and embarking on pregnancy tomorrow, it gets me to Somesh. It says GDM today, NCD tomorrow. Okay, so how do you connect? You have seen the best and the worst of both the worlds, I may say, because you had a long tenure in the public health space through Japago in India. Now you are located in Baltimore and of course working in many different countries, I'm sure from the HQ of Japago. So preventing illness and promoting wellness, how can it happen through Health and Wellness Center? That was again another question posed in the chat box, that there is so much potential probably in strengthening the capacity of the healthcare providers in the health and wellness centers, which 150,000 is the vision of the government. So just imagine if preventive healthcare can be offered there. So what are your thoughts and suggestions for especially India country context with your rich background experience, Somesh?
Thank you, Dr. Hema. So I'll make this brief, and I'll more talk about the program strategies. That's where my strength lies, implementation and implementation at scale. So obviously, I'm very enriched by all the technical inputs, including the latest research that's coming in. I'll share some of my insights on the program strategies. What I have seen working. So, I from the strategic and implementation perspective, I think of a 5-pronged strategy. And most important, probably the way to start is first measuring the maternal weight gain and maternal weight. I think we are implementing large-scale ANC programs, both for GDM as well as overall ANC strengthening platform in India and other countries. And the first thing that we realize, maternal weight measurement is a big issue. So unless you understand that the magnitude of the problem and the gains that are happening, whether it is less or more, and we are talking more here, but less is also a problem. That is such an infrastructural fundamental issue we have to talk about. From the Indian perspective, how do you ensure linkages with the NPCDS program of MNH and NPCDS program? And then how you strengthen the antenatal care package, especially focusing on GDM and maternal weight gain, and then how you use the findings from this for advocacy. So, this is not moving. Yeah. So for first thing I would emphasize is standardizing measurement, making sure that all ANC platforms, including the last mile VHNDs, where 70% of ANC happens, there is proper measurement, capacity for both in terms of competency of the providers as well as the standardized weighing maternal weighing machines, because we are finding that is a big problem, and the lack of knowledge of what is an adequate weight gain is another big gap in the competency, something that has been not emphasized enough. We also think that, and we are trying to do some of this, and for making sure the antenatal care platform is strengthened, I think of it in 3 broad components: competency, commodity, and accountability. So for the competency, for the commodities, I think there needs to be more important convergence between the NPCDS, the National Non-Communicable Disease Program, and MNH platform. So because thereby you can leverage some of the commodity and infrastructural resources from the NCD program for the ANC platform, strengthening the ANC platform, as well as the building the capacity of frontline workers. You see, the provider is the same at the ground level. It is the ANM and the ASHA, especially either it is VHND or in the health and wellness centers. Hundreds, thousands of them are built. How do you make sure that at a more policy level, more program management level, you drive some of these convergences so that you can optimize resources at the last mile? GDM screening, Dr. Hema talked about. We Japaigo implemented a program in Hoshangabad in very close collaboration with FOGSI, and we had leadership from Dr. Hema throughout the designing as well as execution of the program. And we did demonstrate on a implementation model for execution of the national guidelines of GDM. And we found out that the bottom line, that this can be replicated at scale. We got to the whole district, and now that it is being scaled up throughout the state now. 10% of women, 9 to 10%, we found that they were positive. And the key here that we noticed was how do you, across a fragmented health system, provide that continuity of care, because GDM is just not identification, but continuity of care after a woman is identified. So medical nutrition therapy in some cases, the specialized therapy. So again, I'll go back to where I started. Need for multifaceted strategy, starting on measurement and then making sure of optimal utilization of resources through connections between MNH, ANC, and policy and program convergences, and then taking all of this through advocacy for district, state, and national level authorities.
Yeah. Yeah, thank you so much. To tell you the truth, even the OBGYNs as specialist consultants give very little importance to the measure of the weight and tracking of the weight, because some of my colleagues in the previous series of programs of discussion on FIGO, dissemination of the nutrition checklist, they said we will only bother about the weight restriction if her sugars are high. You know, the thinking begins and ends there. So it is not only the ASHAs and the healthcare providers, etc. So one simple thing, the tracking of the weight, you know, somebody monitors it this visit and somebody else the next visit, and nobody is actually seeing comprehensively how much the weight gain is. So that again is within itself a continuum of care. So such simple measures, you think, what are the challenges in implementing such simple? This is not rocket science. I mean, you don't have to teach her how to take the weight. So what do you think can be transformational in this simple, you know, the initiative of a weight measure and tracking?
So one of my roles in US is innovations. So that's where, you know, I try to bring that hat into this. So so there are new technologies that is coming. That's why I use the word standardization of measurement. You rightly pointed out, you know, there is a measurement bias. People, you know, everybody, when you do that measurement, somebody else does in first trimester, somebody else in second trimester, different places. So what we are trying to do is there are new technologies that are coming in, which will use, it's simple, first, not complex, but frugal technologies. And then those having digital technologies, which are standardized, quality assured, but which have which can through what we call IoT, in you know, Internet of Things, directly transmit the weight to the ASHA's ANM's Anmol platform, right? So that's where, you know, that you can minimize the non-standardization of measurement, as well as the measurement then goes directly into the RCH platform and register, so that, you know, you can then track it over time, and the deficiencies in manual entry etc. are minimized. So we are trying to implement such a program in Rajasthan at a large scale in Udaipur district, where we are using these technologies to minimize some of these biases.
Yeah. So meanwhile, Vani asked you a quick question on the chat that the weight gain during pregnancy, what are your thoughts on that? Because for us as clinicians, restricted weight gain of 6 to 8 kilos for a hyperglycemia in pregnancy patient, average weight gain of 10 to 12 in a normal pregnancy, and we wanted to gain 2 to 4 kilos extra in the undernourished and severely anemic kind of a low BMI patient. Would you agree on that, Somesh?
Absolutely. So, so what is the question there, Dr. Hema? Is the
your views on gestational weight gain chart?
Okay, so see, for me, again, coming from an implementation background and implementation expertise, for me, you have to give us the chart. You know, the OBGYNs and the scientists have to give us the chart. Our job is to take things introduce and execute at scale. So for me, the chart that the ones that have come recently are, how do you translate that and get it incorporated in the training manuals, guidelines, job aids of the for the provider. So for me,
Somesh, this connects so beautifully to the next question I want to pose to Dr. Girdhar Babu, because is there any simple things in research that you have found, just a simple thing as a weight gain chart applicable to Indian context, for example, which can be taken to scale, because Somesh says that this simple initiatives have to be taken. We have not done enough on that. So what is your guidance to the clinicians as to the evidence-based research gaps that you may have identified, which you think are really, really simple, but crucial, and we have to take it to scale to make an impact? So.
Yeah, good evening. Thanks for having me on this very important panel discussion. There are definitely no easy measures to ensure that everybody starts using weighing scales, but there are good weighing machines. So I agree with Somesh that the best would be to use affordable technology which can scale up, measuring weight everywhere. But more importantly, I feel the reliability is ensured only when there is an intention to use these scales, even if it is technology or non-technology. I think that's where we require a sea shift.
Absolutely. Sir, do you have a presentation to make, as I can see here?
Yes, please.
Yeah.
So my topic was on how do you use evidence-informed solution to scale. Right. So Somesh's foray is in terms of taking it to scale, whereas we mostly are in generating the kind of evidence that is required for scaling up. So I'm splitting my slides into three main things, which is evidence, which is in the first set of slides. Then what are the appropriate interventions? And finally, what are the research gaps and needs? For each one of us, we are looking at our own way of addressing maternal obesity, and therefore to get a convergence in terms of what is feasible is going to be very difficult. So let me put things in context here. If we are looking at solving obesity in pregnancy, during pregnancy, that's already too late. So we need to be looking at through life cycle approach. And this we have established through several studies, and there are real great researchers from India who has found it's not just the overweighted birth, but also the low birth weighted birth, which is the problem. Among them, Professor Yagnik and Caroline Fall have given the first set of evidence. So what do we know so far? We know that through the intergenerational factors, children can be programmed to have obesity either through the overweight pathway at birth or through the low birth weight at birth. So both would lead to obesity during adolescence or later. So if you have to intervene, probably we have to intervene there. Add to that, now there is micronutrient deficiency, which is transgenerational in especially women and girls. So therefore, there is a mismatch in the kind of nutrients that will cater to already existing micronutrient deficiency, which will also lead to obesity. We have established a cohort by name MASTI. I wouldn't go into the details, but what we found is we are following up women from the government hospitals where low and mid socioeconomic group women generally come. Among them, 9.7% are obese, more than 16% have GDM. We published in the clinical epidemiology showing that GDM mediates the effect of maternal obesity on infant adiposity, which means that obesity is as such bad, but adding GDM will put the kids at greater risk. Further, from our group, Deepa published recently that among the food that the women consume, even during pregnancy, red meat is associated with increased risk of GDM. Further, this is to be published, already accepted. We found that there is higher risk for children to be obese and short in height if they're delivered through elective cesarean section compared to emergency cesarean. This is accepted in pediatric research, and it will be published probably this week. And further, immediately after birth, we showed that breastfeeding, as simple as it, can actually reduce obesity. And this is actually even worse among the boys compared to girls. So these are no rocket science. But most importantly, coming back to the measurement issue, which Somesh mentioned and also which Hema ma'am brought, we showed that mid-upper arm circumference is better in terms of showing the obesity in the pregnant women compared to the other anthropometric measurements that we have seen. So using this evidence, I wouldn't go into the other details, we can actually come up with a scale if there are consensus around what are the important risk factors in pre-pregnancy or even adolescence, which will put them at higher risk of having higher adiposity in children or obesity in pregnancy. Those are the things we need to look at as a low-hanging fruit. And for this, we need to be addressing obesity as a life course phenomena, not just at one point of time. I'll come to the interventions. There is not many interventional studies done in India, but looking at interventions only from one specific RCT will be probably not worthy. But we need to understand that there are several determinants of triple burden of malnutrition in women. This won't change by addressing only one domain. We need to be doing a concerted focus. And for that, a portion should expand into other domains where there is some deliverables within a short span of time. And in order to address pregnancy related either obesity or complications further, we need to be looking at primordial prevention, which begins right in the birth and early childhood, from preventing children from becoming obese, and primary prevention where children are already obese and we try to control, make them of normal weight during pregnancy. Secondary and tertiary prevention is already too late, where the women are already at a higher risk for further complications. We need to shift our focus from one point of time. What works? There are some evidence available from India. When they tried 5 different prenatal behavioral approaches, what really worked was diet intervention alone, more effective than the others. And also in the groups that had some kind of physical activity, there are 2 groups. There the weight gain was optimum compared to higher weight gain in the other groups. So there is a combination of some diet intervention and physical activity that might be useful during pregnancy. But again, not just pregnancy, we need to be looking at in adolescence. There are studies done in Haryana where it shows home intervention alone is not effective. So finally, I come to the last 2 slides. These are multifactorial, and the way we need to address these risk factors also has to be at different levels. So can it be just education, which will allow people to refer themselves and screen earlier? Should it be guidelines, or should it be guidelines with the use of some algorithms for management? And what is the use of affordable technologies in each of those? And that's where Somesh's presentation is very, very useful. So if we want to make it scalable, we need to make sure that people can use some simple tools. And those tools, based on the evidence, will have to be developed. So both target screening and also population-wide screening is necessary to change this. Otherwise, we are staring at the future, which is obese and micronutrient deficient, and the entire generations will be suffering from loss of productivity in future if we don't act now. So with that, I would thank the organizers for inviting me for this panel discussion. I'll be happy.
Thank you so much, sir. The tsunami is evident. You really brought it forth in a very strong way, the implications of not acting when we have the opportunity now. Having said this, so one last thing, Vijay Kumar has been repeatedly asking on the chat box that you already said if you do not tackle them pre-pregnancy, you kind of already missed the bus. They're already in pregnancy, but there you're trying to regulate her weight and, control her diet, put her through exercises, do whatever you want. What benefit the child will get in terms of its childhood obesity if the mother is tackled too late because she's already obese and now you're making her, comply with your discipline? Will it have any impact, or we have already lost the game?
No, I think it is not, again, as I said, linear in terms of where we start acting. There has to be concentrated effort at every point, every opportunity that we get. While the school education program should focus on reducing obesity, that program should start right in Anganwadi, not little later. And the same thing should occur in promoting playgrounds. How safe for our urban environment to walk, for the children to cross roads? If that's not happening, we are just programming our generations to become obese. So that requires a lot of effort. And I think only when all of us come together and start acting in different sectors at different levels, some foreseeable change can be seen.
Yeah, and I think mid-upper arm circumference is actually for all the OBGYNs the new terminology, because when we were disseminating about this, we just took an opinion poll about how many can tell us the expansion of mid-upper arm circumference, and the score was a big 0. So we need, to start there. And then if there are going to be charts available, and then foolproof methodology of minimizing the inter-observer kind of measures, and then seamlessly get it onto the desk to see the continuum of monitoring. I think these are simple. If we apply our minds, it is doable, and we are quite hopeful that we will look at the healthier future generation with all the attempts that we are making as on today. This brings us to the last of our distinguished guests, who has been very patiently waiting. First of all, my apologies and thank you very much for that, Naval Vikramji. How have the clinicians started looking at obesity? Is there any change in their mindset, or thode jade hain, chal jayega? Is it just, it's kind of they're taking it casually, or are they changing perspectives? Are they really paying attention to what all obesity can do, and they're trying to do something to curb it?
Obesity, see, there's a lot of information dissemination about obesity, and people are becoming aware about it. Clinicians are taking notice of that, but again, just taking a notice of that is not enough. What you do about it. And you're in a busy schedule, when a patient, a lady comes and you find that she's obese and she's in the reproductive age group, just advise ki khane ka khayal rakhna and exercise karo, vajan kam karo. 3 sentences and next, the patient is gone. That is not enough. You see, what is more important is to give them, just not saying these sentences, but to give them directions as to how to go about it, because that is very important. Telling them ki exercise, walking kariye. How many of the people who are there can really go for a walk for the prescribed 60 minutes safely? That is a big question. And you say ki khane ka khayal rakhna, kam khana. Kam khana means what? So see, the giving the patient a clear instruction, because see, giving clear instruction is very important. If we assume the patient is assuming that it's a lay person, you give a clear instruction that what kind of a dietary changes are required, and it has to be individualized. No, not every patient who is.
Navalji, I just wanted to interrupt you on the confusions that arise both in the consumer's mind and the clinician's mind about the variety of instructions given with weight loss programs, keto diet, some Dikshit diet, this, that, all. Such a mix of, conflicting information. Somebody says this is very good. Somebody says, no, you should totally avoid it. So how do you process these informations to get to the right track of eating right?
You see, what I tell my patients, and I think I would say that in a way it would be better that, see, these various kinds of diet are given. Many of them are just fad diets which are being promoted. So keto diet and Atkins diet and all these, they may be good for a short duration if really somebody wants to lose weight. But again, the rebound is worse than what the weight was previously. So a balanced diet, which is very important, and you can make and a balanced diet in terms of macronutrients, and you may reduce the calories. So the calorie reduction is the key point, and we have to give the patient the choice how to do it. Not everybody can follow the same diet. One size doesn't fit everybody. So for vegetarian, it's different. For non-vegetarian, it's different. Person who can afford can be given meal replacement packets and whatever the commercial commercial diet packets, and they are available. So it depends. And what the kind of individual or the patients that I see in my obesity clinic are the ones who cannot afford any of these things. So they have limited choices, and within those limited choices, we have to tell them that what should be restricted, what should be promoted, so that they reduce the calories, but at the same time, without reducing any micronutrient or any macronutrient deficiency. That is very important.
So what comes across to our minds from your inputs as a clinician's perspective? First of all, we are not thinking enough about it. And even if we are thinking, we are not doing enough about it. And even if we're doing something, maybe we're not saying it with enough conviction, and it is not translating into something that the patient or the community actually does to translate into an actual wake up. Those who don't have the luxury of obesity clinic like yours, where do they go? Who has the capacity to handle them?
I think they have to be, majority of the patients go to a physician, and most of the patients are seen by physicians who are just MBBS, not even MDs. Not everybody has an access to an MD or a DM endocrinology or other specialist.
Right.
So this is required, that this information about how to tackle obesity. And I think as Professor Fionella also mentioned, that the curriculum, medical curriculum of, I think, many countries, including our country, in MBBS as well as probably in the MDs, does not include obesity related teaching, because it is just that obesity is a risk factor for your cardiac problem, your diabetes. So more of the focus goes to the cardiac disease, most of the focus goes to the diabetes. But obesity as such, there is no focus on that. So an MBBS person who's just coming fresh out just knows what is obesity, the definition. Even they may not be knowing what is the Asian definition, and they just start. They are at loss when they come across a patient who asks, "I'm obese, so how should I deal with my obesity?" I think that it's very important to bring obesity management, the basics of obesity management, identifying and how to measure it and how to go about it at the first level, should be brought into the medical curriculum. I think that is very important.
Yeah, thank you so much for bringing forth so very clearly that the capacity building is the core at all levels of healthcare providers, because it is so crucial that both the swings, the triple burden, as Dr. Babu said, whether it's undernutrition or overnutrition or micronutrient deficiency, as how you rightly brought it, all the three, the spectrum across it, we have to know how to handle it, because handling it, as how we have heard from the experts, is a matter which is quite simple and not a rocket science. But to actually get it off the ground, both the population and the segment of healthcare providers have to come on a common platform with enough seriousness to see to it that we walk the talk. So with this, I think in the shortest possible time, 6 of the distinguished faculty have placed before us some very thought-provoking and meaningful inputs and discussions for the way forward. And I thank them all on behalf of the entire team of organizers, the multiple stakeholders who have brought us together, and hand this over to Bharti ji for her concluding remarks. May we stay together and do more together and walk towards a healthier India. Thank you very much.
Thank you, Dr. Hema, for moderating a wonderful session. And within a short span, we have heard from a diverse set of stakeholders about their views. Thank you so much. Dr. Prema is with us, and I think she is the person who has had extensive experience over the past many decades, and I would love to hear from her about her concluding remarks. Dr. Prema, please.
Ma'am.
Thank you, Bharati, and thank you, Hema. Everyone has clearly now realized that overnutrition is a problem. The basic initiative, be it from children to pregnancy and beyond, the weighment and taking height, calculating BMI, extremely simple methods which we ignored all our life ought to become the central core. It is extremely possible today, given the technology. Good weighing machines are available. Good stature meters and infantometers are available. It's not rocket science, but what we need is compliance with accuracy demands, bringing in graphics to help people. You can't expect people to think and talk about how much weight for how much height and where do we go. Do we have South Asian standard? Do we have East Indian standard versus the North Indian standard? No, all that you give are trajectories, whether it is for the child or for the woman during pregnancy. Give a chart as was demanded. These are available. Only thing is access that and promote it. Then trajectory tracing would give you early indication of deviation from the norm and enable you to start at a time when doing something and benefiting within that pregnancy is still in the possible realm. Once you start getting interested in that, clinicians are interested in their patients. So once the importance of this and how far it will enable the mother and the child to lead healthy lives, they will put their heart and soul into it. Till now, we went on telling, this is so simple. We don't have to worry. We will do all the complicated MRIs, ultrasound. That is where we deliver healthcare. Just a mindset change will do wonders. And I'm sure we are all well prepared for it. So go along there. There is nothing to worry at all. I think we are very lucky in India that the overnutrition problem came just about a decade and a half ago. We are very well prepared mentally at the research level and also at the policy level. What is needed is just implemented. It's so easy and you will see the results very, very fast. And thank you so much for giving me the opportunity to talk about this. Thank you.
Thank you very much, ma'am, for your words of wisdom. I'm sure all of you will agree with me that we had excellent deliberations covering different stakeholders, listening to clinicians, listening to public health practitioners, implementers, as well as the policymakers from FSSAI and NITI Aayog. And we have a lot of food for thought and more action is needed. I thank all the speakers, panelists, Chairperson Dr. Prema, and all the participants for being with us today and having very important deliberations on this topic, which is a new emerging area. We have not had enough thinking about it, forget about implementation, but there is definitely a need to take this forward very rapidly and very efficiently. So we are all together in this. I thank you all for being with us today.